All right, want to welcome everyone to today's meeting, which is a special meeting of the Finance, Efficiency, Economy, and Sustainability Subcommittee. And as we always start these meetings, we'd like to start it with the pledge. Vice Mayor, will you please lead us in the pledge?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. As I mentioned, this is a special meeting, and we're meeting today for to address one topic, and that is health insurance coverage, both for our current employees and our retirees, and specifically how we can continue to provide great health care for them while addressing the costs of health care, which continue to increase. And I didn't know if the city manager wanted to say a few words to kind of just kick us off, and then we'll go into our presentation, and we have some comments from the public as well today.
Thank you, Chairman Gates, members of the subcommittee. Thank you for having this special meeting. This is a really important topic, but it's one that requires quite a bit of education first before we can hope to make big decisions, because the decisions we will be making eventually are very big, and you'll hear about that today. I just wanted to kick it off and set some context. So as we know, right now in this budget year, as we're preparing for 2015-16, we're in a balanced state. But we know that from our 5-year core forecast of 2016-17, we face up to a $40 million deficit. So we have about 12 months to figure out some strategies for that. And we are, as this subcommittee actually is intimately familiar, there are many strategies we're undertaking. We have an internal comprehensive review called CORE. We've continued to look at vacancies. We look at our collections, which we'll talk about tomorrow. E-procurement will help us consolidate, have some efficiencies. There's some long-term technological solutions to costly things such as 311 and continued efficiency work. But one thing we're also working on that's very important is healthcare costs. And the reason why that's so important is there's really two things. Number one is just the dollar amount of it. We have grown from $95 million of healthcare spend 10 years ago to $153 million of healthcare spend today. So that's $60 million of growth in the last 10 years. Not out of the realm of the world, but if we can start making an impact in that growth, then it will help our city budget situation. And we think there's some private market solutions and strategies that we can look at that we'll hear about. But the other thing that happens when we save money on healthcare costs, that is the one thing we do that directly affects the employee's pocketbook positively. Because the way we're structured, every $100 of cost for health insurance that we save, $20 goes to the employee, because we split it as an employee, $80 for the city, $20 for the employee. So it has the added bonus of being a way to put money back in our employee's pocket when we find, if we find, and as we find efficiencies. So we have many current efforts, and I'll introduce our team here. Mary Kyle is Assistant HR Director. Mary is a healthcare expert. In fact, she's fairly unique in the world of municipal government, because people like Mary often get hired away to the private sector because of the breadth of her knowledge. We're very fortunate we have Mary working with us at the city. And also our advisor and consultant, Steve Schramm. They'll tell you a little more about Steve, but he also helps us keep up with the trends in the world of healthcare that we're going to talk to you about today. But we have quite a bit going on. We are doing a dependent eligibility audit. We talked about that in this subcommittee, and you approved us going out for that. We are looking at our pharmacy benefits. We're looking at our healthcare advisor. So there's a lot of work going on here. And I would talk about with our healthcare, I didn't ask you to think about a pane of glass that starts as clear. And that's like our health plan was maybe 30 years ago. And every year we paint a layer of paint on that piece of glass. And so now 30 years later, we have 30 layers of paint in this thing. And so what we have to ask ourselves, are we at a point where we want to put another layer of paint on the glass, or do we want to either strip all the paint off and start over? How do we want to do this? That's really where we are here. Is 30 years of accumulated tweaks and of our plan. Are we at a place where we want to try and refresh the whole concept from the beginning? And that's really what you've invited us here to talk about today. So there's some time pressures on us. One I mentioned is our budget situation, where The sooner we can make a dent in our healthcare costs, the better off we are. The second one is, as Mary will explain, is the Affordable Care Act has something that is known as the Cadillac tax that's looming for us sometime in the next 3 to 5 years, and that sort of shifts depending on who's looking at it, but Mary and Steve will talk about that as well. So the clock is ticking, which is why I'm very thankful to you for scheduling us to begin talking about this. There's a lot of work out there. The private marketplaces are really changing, and we've been looking at those things. And so now we really want to work that with everyone. I want to end by just saying a big thank you to our labor units. I have a city manager's healthcare task force, which has a representative from every labor organization in the city. There's 7, as well as every level in the city. So the unrepresented employees and the retirees are also part of that group too. They've been working with Mary for over a year on this subject. And so it's really important to frame up front too that whatever we do with healthcare, we need the employees to be on board with, because as you and I have talked, Mr. Chairman, there's really nothing more personal, maybe even more personal than the paycheck, is the health care that is provided to employees. And so we need to handle that with great care and sensitivity, and this subcommittee has been very good at that up to this point, even as we talked about something like a dependent care audit. So thank you for that sensitivity as well, and we're just pleased to be able to have an open discussion and talk about different ideas without the pressure of having to make an action right away, and we just look forward to hearing what people have to say with that. So with that, I'll turn it over to you, or we can go directly to Mary and Steve.
Yeah, no, thank you for that. Unless my colleagues have any questions, that was a great summary of kind of where we're at and what we're looking forward to doing today. And so with that, I'll turn it over to Mary.
Turn my microphone on. So first, I'd like to introduce Steve Schramm. I know Ed spoke about him a little bit. Steve has been our strategy consultant for about 7 years now, but through the consulting firm, even prior to that, he's worked on the city's account since about 2003, off and on. So we have a general benefits consulting firm that does day-to-day things for us, but then we rely on Steve to help us work through healthcare strategy. So anything you want to add to that, Steve? All right. Then we'll go ahead and jump in. I do know that healthcare can be complex, so if you have questions along the way that you want Steve or I to answer, feel free to just stop us and ask us questions as we go. So really, the issue here is city-sponsored health insurance for both our actives and our retirees. And when we're looking at how costs have increased over time, we've increased nearly $65 million over the last 7 years. And looking at healthcare, it is one of the city's top 10 ongoing expenses that the city incurs. So as Ed talked about, one of the things that we are concerned about is that looming excise tax, also known as the Cadillac tax, that could impact the city beginning as early as 2018, but by the year 2022, that could be in excess of $11 million. So that looming excise tax is something that we're very concerned about and certainly keeping an eye on. Many large employers are rethinking their role in employee health care, looking at strategies to contain costs, making sure that things are affordable for both the employer and the employee. And the private health insurance marketplace is becoming an option for many employers. While there might not be many public sector employers that have moved to the marketplace, there certainly are many large corporate firms that have looked at the exchanges as an option for them. And so obviously making sure that we're providing quality health care for our employees that's part of a comprehensive benefit package is something that we're very concerned about so that we can retain the employees that we have and attract new employees to our organization. So a little bit of background here. When we look at healthcare costs, and this is national data that you'll see up here, cost increases are outpacing CPI, and then there's always that looming Cadillac tax out there. So as you look at this chart, if you look at the narrow kind of reddish orange colored line at the top, that is health. For the years, it's been anywhere, it's kind of been in a range of 7 to 8% over time. And the bar graph down there that you see where it talks about healthcare trend after plan design, that would be what it looks like when you've applied things like co-pays, increases to co-pays, deductibles, co-insurance, any kind of cost sharing or reduction in plan design that you might.
So if we had just kept the plan exactly the same, for example, in that first year, it would have gone up 8%. But with the tweaks or the layer of paint, it was brought down to a 6% increase. And so that's what's being shown.
And so what we're seeing here really is that healthcare increases are outpacing the CPI. So it's just hard to keep up and have healthcare be affordable for employees.
Mary, let me add, Chairman Gates, council members. So the reason we bring up that comparison to CPI is the city of Phoenix and their health benefit spend has actually been lower than national averages. When the city moved to self-insurance, it was able to reduce its rate of growth by controlling the cost levers associated with the health benefits program. And so we were able to beat national averages, but that's not going to be enough going forward because the Cadillac tax is actually indexed to CPI. And so now we have a new bar that we need to be shooting for, and it's a much more challenging bar for us to hit.
We've kind of talked about Cadillac tax, but can you just give us a quick, what does that mean? Does it apply to everybody? Can you avoid it? Maybe just to frame the discussion.
Yeah, so the Cadillac tax is basically an excise tax where the federal government sets a threshold and they say this is the threshold that you're looking at with regard to premiums. And anything that your premiums are over that threshold, you have a 40% excise tax on that amount that's over that threshold. So it is very expensive. So part of what you have to look at to reduce the opportunity to hit that excise tax is how do you decrease the cost of your plans. So there is some guidance that's come out recently from the federal government about what's included in that premium, but there's still a lot of things that are unknown. Excuse me, like what's not included in there or what's not clear whether it's included would be things like your flexible spending accounts, voluntary vision and dental plans. So still waiting on some of that additional guidance to come out from the federal government. But we know that we're going to hit that excise tax in the year 2018, at least for one of our plans. And that's probably the year that would be the least expensive for us at about $500,000. But then as you look at future years, that just continues to grow. And based on what we know today and some predictive modeling that we've done, that's where we've come up with that number that we could hit that $11 million that we're paying in that excise tax by the year 2020.
And that would be paid by the city, or it would not be paid by the employees?
Well, it could be either way, because really when you think about other things that we've already been impacted by with regard to healthcare reform, some of the fees and the taxes get rolled into our premium structure. So it impacts not only the employee, but also the employer.
Thank you.
You're welcome.
Sorry.
Nope, no problem here. So as we look at, ways that you reduce healthcare spend, there's really a couple paths that you can take. One is to reduce plan costs through cost shifting, and that is through out-of-pocket payments for your employees. So for example, you're increasing co-pays, deductibles, co-insurance, those kinds of things. Or path number two is that you're finding new ways to manage healthcare spending to trend at CPI. So if you think about, in the healthcare world, as you're setting your premiums and you're looking for costs, you have various levers that you can push and pull. So obviously reducing plan design, increasing cost share, those kinds of things are one lever. Another lever, for example, is looking at other alternatives for how you promote your plan design. Anything you want to add, Steve?
So as we've talked in the past with the Healthcare Task Force, we've primarily focused on the levers in path one, which is what Mary mentioned. Looking at plan design, looking at ways of getting the employees and their dependents to be better consumers of healthcare. But at some point, you only can go so far with that before you begin to become at a level where it's challenging for the member to retain their access to health care and still meet some of those out-of-pocket expenses. And so what we challenged the task force with that Ed was talking about a year ago was, could we come up with a new way of looking at our health benefits and do it in a collaborative way so that we were jointly coming up with solutions that didn't focus on this first path that was really cost shifting and instead looked at more collaborative levers like the private marketplace that we're going to talk about today.
And just want to put the potential $11 million Cadillac tax into perspective. How much did the city spend on healthcare costs last year?
So if, Chairman Gates, council members, if you were to look at the total spend between medical, pharmacy, and dental, we're talking about $180 million.
About 194 million, but that includes medical, dental, pharmacy, actives, and retirees combined.
Thank you. Yes. Councilman Ware.
So if 184 million is the total, Ed, you and I have talked about this pretty extensively. So I think you're optimistic. A best case scenario was you thought maybe we could save 20 million. Is that correct?
I would be ecstatic if we could do that.
But that was, I'm saying that's the outside, yeah. So,
Yes.
so 20 million, so
Given
it's
our-
20 million,
yep.
so we would reduce $184 million per year to 164 million. I mean, that would be, that's good.
That would be an
there's
ideal
no doubt
goal.
that's worth looking into and so forth. By doing it with the retirees already, I think you had told me we were going to save 5.
We think so, yes.
So the 184 is already going to become 179? Or did you already back that out?
In terms of our discussion here, yes.
It was for every-
The
184
numbers-
is for everybody.
The numbers change based on what you're looking at, but the concept is yes, that.
So the 184 is sort of our current peak, and then the 20 is backing it out of there. But we're definitely going to be backing 5 out, or hope to back out 5 next year. So the 184 will already become 179.
We hope that our experience is that.
I think you
Yeah.
understand what I was saying. Okay, thank you.
I think we'll cover a little bit of that as we continue on in here
I
as
just
well.
wanted, since you mentioned that number,
Fair question. Do you want to take this next slide?
So when we're talking about the levers, it's interesting to focus on what's the effect of the levers. And so this is national survey information done by some of the major benefits consulting firms. And what they've done is they've stratified the purchasers in the healthcare marketplace between best performers and low performers. And the reason they do that is they want to give you an idea as to what the impact of an effective benefits strategy can be. And it needs to be a comprehensive strategy. So it can't just be the levers that we've talked about in the past, cost sharing, co-pays, co-insurance, those kinds of things. It needs to be a more effective approach that looks at an overall purchasing strategy and tries to leverage the position that the city has in the marketplace and leverage the marketplace itself. And so you see there is a significant amount of dollars potentially to be saved if you take the path of those employers that are categorized as the best performers. $2,000 a year is a significant amount of money, and what it represents is an opportunity for the city to, as the city manager says, not only reduce the expenditures for healthcare benefits for the city, but put money directly back into the pockets of the city employees. And so it is a process of looking at how we, the city, become one of the high-performing benefits purchasers. And part of that needs to be a paradigm shift. We need to think differently about how we purchase our health benefits. And so what that means is, in the past, as part of our conversations with the task force, we have tended to say we want to look and see what other paths people have gone down, and they have been there for 3 to 5 years, and what has been their experience, very much focusing on municipalities. Instead, now what we're saying is we want to be in that group of best performers. We shouldn't limit our view to just the public purchasers. We need to be looking at private purchasers as well. And so that's why we brought to the Healthcare Task Force several of the concepts that we vetted included things like high-performing networks. You also hear them referred to as narrow networks, where you go out and you identify the best of the healthcare provider marketplace and you say, we need to have a different purchasing model. We've talked with the healthcare task force about private marketplaces. And of the conversations that we've had, the private marketplace has represented the best combination of interventions that will help us achieve the goals in a collaborative way with the city employees. And we'll talk about what those collaborative goals are in some of the next slides.
And can you take just a second again, kind of getting our definitions out here? What is a private marketplace?
So a private marketplace is really kind of, if you think about healthcare exchanges, there are really two kinds of healthcare exchanges. There's the private marketplace, which are typically run through larger organizations. So for example, Towers Watson has a private marketplace, Mercer has a private marketplace, other big firms like that have a private marketplace where really you're designing your plan design and it's a marketplace just for City of Phoenix employees to go. So we would be the plan sponsor, we would still be the strategic partner in determining what our benefits are, but you would go through that private marketplace to get your health insurance. If you're talking about a public exchange, the public exchanges are either run by states or by the federal government, and you probably know those as a result of healthcare reform.
Okay, so we're not talking about healthcare reform or ACA or anything like that today, right?
That's a component of what we're talking about because there are some nuances to this that I think we'll cover as we get a little bit further along in here.
But the discussion is not going and becoming part of Obamacare or ACA, right? Just to kind of get that elephant in the room.
That is a correct statement. Yep. Yeah. And so before we move off of this slide, really when you look at, the low performers compared to the best performers, some of the things that kind of differentiate those groups from one another are in the best performance, you have high performing networks or high performing physicians in there. You typically have more aggressive care management for your members, as well as vendor oversight and management, more aggressive pharmacy, and then well-being coordination as part of that as well. So I think this will answer your question now about, what is an exchange? So it really is a choice of products and plan types that are available out there. And that focus of control moves from the employer to the employee. So if you think about how we offer health insurance today, the city and our healthcare task force design the plans that we have. So HMOs, a PPO, a high deductible health plan, singular family coverage, and we kind of design that structure. Where now you're offering employees a choice of plans and typically more choice in carriers than what they might have today. And then they also have kind of that online shopping connection between that product and the consumer. So the employee has the opportunity, or the retiree, excuse me, to go out and really look and see what's available out there in that plan offering. So as we look at those private exchanges, so they're rapidly gaining uptake for active employees. Large employer groups are looking at this as a viable opportunity to offer quality benefits to their employees. There's also proven Medicare plans for retirees that offer really a win-win proposition for both the employee or the retiree and the employer, because there's substantial cost savings there.
It's important to note on retirees pay 100% of their health care costs with some post-employment benefits from the city. But an active employee, it's 80% city, 20% employee. For retirees, it's the whole enchilada for the retiree. So that has an impact as well.
And then for that pre-Medicare group, there's really some good developing opportunities in the exchanges out there for that group. So we've talked about, options for our Medicare eligible retirees with the Healthcare Task Force for quite some time. But because there haven't been good options for that pre-Medicare group, that's kind of been what's stopped us from moving forward in that arena. But now there's good resources out there for that pre-65 group that make that a viable option for us as well. The exchanges also simplify the administration for employers, and it allows us to be more creative with an employer subsidy strategy. And then if you think about the public exchanges, those are good exchanges for really a certain workforce segment. So if you think about low wage or subsidy eligible individuals that could get a federal subsidy, that's a really good option for people to be able to get affordable health insurance. It's good for part-timers, early retirees, COBRA, continuees, a good resource for them as well. So, and again, that subsidy that's available out there makes it an attractive option for folks. So as we look at active employees, part of what makes the exchanges attractive for us are cost containment. So when you get participant engagement and they're looking at how they're spending their dollars on healthcare and really understanding the cost of healthcare, that engagement really helps with cost containment. Again, the high-performing networks, the carrier relationships, and then the consumerism. Employees really get to decide how they're going to spend their dollars on health care and what's important to them. Whether they want something that pays, better than another plan, they want something with a higher deductible, it really allows folks to customize the needs for them or their family. Also, when we look at efficiencies, the administration of how you administer benefits becomes very different. The vendor management relationship is different. Plan design, communications, all of that kind of play into that efficiency. And as you think about right now, when we do communication, we do it just for the city of Phoenix. But when you have an outsourced marketplace vendor that helps you with that, that's really skilled and experienced in that, you get some of that best-in-class design there. So looking at bending the cost curve, and then again, that engagement for employees. So for example, and if an employee needs an MRI and they know that they have a deductible that they have to meet, there's some engagement for that employee to decide how they're going to spend those dollars. Whether you're going to go to a hospital network to get that done or a freestanding clinic where maybe you can get some of those services for less cost. So engaging employees in that healthcare spend is really important. High performance elements that help drive cost out of the system for us would be things like multiple carriers, that customized care management approach, the aggressive pharmacy pricing, integrated well-being services. So coupling wellness along with that plan design in more of an integrated fashion than what we do today. And then the tools and technology that's available for members for that better decision making. Those are part of what's driving the cost down in the plan by going to an exchange.
Very important point. We've talked about the strategy behind improving the city's purchasing about once every 2 to 3 years. We try to do a very comprehensive review with the Healthcare Task Force to make certain we're in the right spot position-wise for our purchasing. And what we've seen in the past is we were unable to get each one of these areas to align. So we saw the marketplace develop and bring some of the cost containment capabilities to the table. And we saw the marketplace develop and bring some of the consumerism. But what was lacking was the ability to tie that together with a strong customer experience and the engagement that's talked about on the bottom of this slide. One of the things that's very, very important is that the city recognizes that the typical city employee is a risk-averse individual and so needs a significant amount of assistance to help them make their benefits choices because they want to make certain that they are getting the best and most appropriate deal. And so the alignment of these 5 areas has been a very important leap that has taken place in the marketplace in the last couple of years that didn't exist previously. And so we want to try to take advantage of that alignment and do it in such a way that it gives the city employees and their dependents, retirees, the correct customer service experience on the front end, the choice right at the point of purchase, follow up and continuity with the advisors, and then the high-performing network for the actual service delivery. And so we think through the conversation that we've had with the Healthcare Task Force, we are able to align the goals that the task force has with what the marketplace can offer. us. And so that's why we're very interested in pursuing the concept of a private marketplace for the actives and the retirees.
So the typical structure for an effective exchange would look at, if you look on the left, that consumer-guided enrollment and call center experience that Steve just talked about, really helping employees and retirees understand how do you make the best choice based on what your individual or your family needs are. And then if you look in that center column that's kind of yellowish colored, looking at those high-value design elements that we've already talked about, you could look at a self-funded or a fully insured exchange model. You could have multiple health plan choices, including dental and vision plans. And then there's top carriers in all 50 states, including Puerto Rico and Washington, D.C. And then on the right-hand side, looking at that sophisticated administration platform that the city would have access to that includes data interfaces and vendor management.
Important point in this slide is there are multiple private marketplace models that are out there. Mary talked about you have consulting firm driven ones, you have carrier driven ones, you have broker driven private marketplaces. We're not saying there needs to be one particular perfect solution. Instead, what we're saying is, as part of our purchasing decisions, we have certain goals and requirements that we have in each of these three columns. We're going to go out to the marketplace and say, here's what we need you to bring to the table, and then you have to demonstrate you have that solution that fits our needs. That's the way we tie this in with the Healthcare Task Force desires and goals.
So if I were an active employee and I was looking to get health care through a marketplace, part of what you get is that shopping basket experience that we talked to you about. So typically an employee would start out with a simple questionnaire answering questions about the kind of health care they need, who are they covering, what kind of services are they accustomed to needing, and what kinds of services have they needed in the past. Then they get some additional educational information and guidance, and then they receive a personalized recommendation. So there's some algorithms that run behind a software package that come back and say to the employee, based on the information that you've given me, here's the 2 or 3 plans that really would best suit your needs. So the employee then has the option to pick that plan design portfolio that really looks at what's important to them. So, as you're looking through all of this, price transparency for the individual, marketplace of choices, predictive analytics, lots of things that the employee can engage in looking at that choice for them. We've talked a little bit about the drivers of savings and what it is that drives savings for both the employee and the employer, and then also those administrative efficiencies that you get as the employer on the back end of that as well. If there's no more questions on actives, I can move on to retirees.
And let me just also say here too, I want to be clear that this is not commentary on our current providers. This is real. The providers provide the plans that we ask them to give, and employees are very satisfied with our providers in that regard. This is about plan design. This is about what we ask people to bring to us, as opposed to a commentary on what people are giving us today. So it's not about our current providers of Cigna or Blue Cross. It's about what we're doing, because we've put layers of paint over those guys too, and so it's about how do we peel those layers of paint off, start with a fresh piece of glass, whatever the image is, and that's really what we're trying to get at here.
Questions?
Yeah. So I just want to make sure I'm clear. As I said, you and I have talked about this for several hours now, and Mary and I thought I was clear, but I just want to make sure. I mean, it's going to be the same providers, or potentially could be. That's correct, right?
It could potentially be the same providers that are
not
part
100%,
of that,
but that could change
marketplace.
anyway. So,
but you may have additional providers that are part of that marketplace as well. So it wouldn't necessarily be limited to 2 carriers out there.
Right. I just want to make sure the way you said it, it made it sound like we were starting over with all new carrier, and that's not the case. I mean,
I'm talking about plan design.
I was pretty sure, but if I was confused, maybe somebody at home too. Okay, just as long as we're straight about that, that's fine. Just want to make sure.
Any questions? I'm trying to create an analogy because these concepts are pretty, I think, foreign for a lot of people. But I thank you for pushing the envelope for us. It would be like, again, to use a private sector, experience. You go with the Charles Schwab for a 401k, and sure, you say you're our plan administrator, and then they go out and they pick lots of different funds and make those available. The employees could invest in certain ones. They don't have to invest in all of them. Is it kind of that concept where someone comes in, they run it, and then
It is. So if you kind of use that same analogy, let's assume that you have 100 funds out there that you could pick that you want to invest in. But part of what you need to answer in making the selection of those funds is how risk adverse are you?
Right.
How much money do you want to invest? How long do you want to invest? So you have to kind of put those answers around what you're going to pick in those investment options. So if you thought of healthcare kind of in the same way, you're going to say, I don't really use healthcare, let's say, other than maybe preventative and, periodically I get sick or my children get sick. And these are the prescriptions that I might take. So you might enter those kinds of things into there. And then the other questions that you might answer are, who are the physicians that you use? Not just you, but your family members if you're covering your family. If you had to go to the hospital, what hospital network do you want to use? So you're answering some of those questions, and that's really what comes back after it runs those algorithms to say, based on that information that you gave me, here are the 2 or 3 plans that are really the best fit for you. So you could decide, I want this one, or you could say, you know what, I don't want any of those, and I want this one. So you really have the option to pick and choose and customize your health care for your individual needs.
And Chairman, to continue with that analogy, much like Schwab makes certain that you're asking all the right questions and that you're being thorough enough and comprehensive enough, and they're helping you with the review of the options available, the private marketplace has a benefits advisor, and they make certain they help you navigate through a very complex decision-making process. They ask you about your healthcare usage for the past year, for your family, who your providers are. Those are the kinds of support capabilities that frankly didn't exist in the past, but now are sufficiently robust that we think the city should have a long, hard look at a private marketplace, because we can provide the support for the city employees to help make better informed decisions about their health care and their health insurance coverage.
And so can you speak to how this process can save money? Because it sounds to me, so far what you said is better customer service for the employees. So can you talk about then how does that lead to lowering costs with what sounds to me like people would actually be receiving better health care or health care that's better tailored to their needs?
So, Chairman, I'll hit one of the pieces, and that is for a large portion of the city's employees and retirees, they're actually overinsured. We are purchasing more insurance coverage than they need. And one of the consumerism benefits associated with a private marketplace is actually having someone help you look at your options and say, we've run the calculator a couple different ways, and we've talked with you about what your situation is in your family and how risk averse or willing to assume risk you are. And we really think you could take this less expensive plan. That's one very specific way it can save the employee as well as the city money. Another way is one of the things that we talk about when we do these strategic reviews of the city's health benefits purchasing is we only go out to market once every roughly 3 to 5 years. And so what we know is we're able to get really good deals in the first couple of years of those procurement processes. But then over time, it degrades a little bit, right? The private marketplaces are actually going out and doing their negotiations on an ongoing rolling basis. And so they're going to bring the best in class and best in market pricing on a constant and consistent basis. And so now I've got better purchasing decisions. I've got potentially better pricing. And then the last piece that Mary talked about is the integrated care management and wellness. So one of the things that we would say is a requirement of a private marketplace is that they bring an integrated solution to the table for us. And it has to be something that is not just face value. We have to see demonstrated results, participation, penetration rates, and effectiveness and ROI associated with it. One of the other reasons why we're at this point having this conversation about private marketplaces is now there are a couple years worth of experience where we can actually look at real results and say whether or not they've been successful. And so we feel very comfortable that the time is right for us to have this conversation about the city looking at changing its purchasing paradigm.
And to that point, are there any instances where state, local government have become part of these marketplaces, and do we have any data points if so?
Ohio is going to a marketplace beginning in July of this year. Theirs is a little bit what I would call a modified marketplace, but we are starting to see some movement into that arena. And while we might be pioneers, should we decide to do this, we're not pioneers from the perspective that the private sector hasn't already done this. CenturyLink, for example, is on an exchange. Kellogg's is on an exchange. So there are some big employer groups that are out there that have done this already.
Yeah.
But to your point, we are at the front edge of local governments, certainly, in that. And that's a little uncomfortable for us. We're generally not the bleeding edge of things. We like to let others do that. And that's why we're here talking so early about these ideas, because it is, as Mary said, it is a little bit of pioneering on the government level.
Councilman Waring.
So, some of those employers would have considerably more employees than we do. So they're almost like government entities in a way. What could happen that would be a negative? You've got basically, or at least potentially, the same people providing the insurance. I assume it would have at least as big or bigger breadth of doctors. What's the downside? We've gone back and forth about this, so I'm just trying to figure out what could happen that would be negative since we're pioneers. Columbus, he could have found that the world was square or whatever and drifted off the side. That would have been bad.
But
he didn't know, so let's not be that. But it didn't happen. So
Chairman Gates, Councilman Waring. So there's always the possibility in any risk contracting environment that we are unable to achieve the savings that we've projected because the care management programs aren't as effective as we thought.
I interject there,
Sure.
But so we don't achieve all the savings, the $20 million that was referenced before, but how would price go up? I just don't see that. That would be obviously bad. That's what we're not trying to get. But how would that happen?
So, Chairman Gates, Councilman, as we enter into the marketplace, we will have as part of the procurement process, estimates about the types of plan designs that we're looking for. So for the first year, the likelihood that the pricing will be at such a level that it will cost us dramatically more than we've projected is unlikely. But in out years, second and third years, there is the possibility that the care management is not effective as it has been previously, that we don't get the shifting and the consumerism that we had anticipated to lower cost plans. And so there is the possibility, as there is with any health benefits program, that the risk of the healthcare spend is not successfully managed and does increase the rate of growth of your healthcare expenditures.
Go ahead, Marianne.
I think the other thing to share with you here is really when you think about, how can we contain costs, some of the things that we have today, you're not going to lose. So if you think about we're a self-funded plan, we have to have stop-loss insurance here at the city. And so that means if we had catastrophic claims, then we have stop-loss insurance that's going to come in and pay once we hit that $1 million threshold. So you don't lose some of those kind of safety nets that we already have in place. Right. What could impact our plan? A year with a lot of catastrophic high dollar claims, but that could happen to us today. You know, and I'll tell you, that's one of the things that I think we've managed really well since we went to the self-funded environment back in 2005. Prior to that, we were seeing pretty wide swings in what our premium increases were. You know, we'd go from 5% to 18% to 10%. So we were seeing these jumps all over the place prior to self-funding. One of the things that's done for us since we've been self-funded is kept us kind of in a corridor of anywhere between 3 and 7% with our rate increases. So it's been very effective for us. So, you know, obviously there's risk with any kind of change that you do, but I think we have safety nets in place to help protect us from that as well.
I think what I would say about it is, from a non-healthcare perspective, is exactly because of what Councilman Gates asked. Because we don't have any other cities to say what happened when they did this specific thing, we're sort of projecting what we expect, but we don't know because we don't have an LA or a Chicago or a Houston or even a Tucson who's done it to look at their experience and see where those pitfalls might be. So because we're out in front, we're having to depend on whether our projections are exactly right or not. I think that's the risk on the price side. And then on the care side, if you think about it, it's been, we've, as Mary said, we have had great experience with our providers all these years. And so people are comfortable with that. And this is about perhaps having to change some of that, how we deal with it. So just from the human side, there's a risk of this is different than what I've experienced. And how do our human employees deal with that sort of change would be sort of the non-monetary thing we have to evaluate.
Well, I guess to what Mary said, and this isn't criticism in any way, obviously prices are going up everywhere on everything, but specifically in healthcare. But it has been increases pretty much every year of 3 to 7%. That gouges a little bit out of paychecks and so forth. I think I agree certainly with Ed. We wouldn't be talking about making a change. It was strictly based on the product provided or the service provided. This is strictly a money-saving effort. To that end, you and I had talked about specific, maybe in the whole, things are going fine, but there could be specific instances where it would hurt individual families, and obviously that's what we're trying to mitigate. Obviously that's what you're trying to also get across to the employees, that we don't want to have those circumstances. Can you talk a little bit, if this is the appropriate time, about what can be done to ensure that somebody who's covered now with the good product we have now doesn't go ahead and say, yeah, go ahead, we'll make this change, and then all of a sudden they're left hanging?
Right. I'll ask these guys.
So one of the things,
Forward to the retirees, I just thought that was.
Chairman Gates, Councilman, one of the things that we do as part of any procurement that we do for the benefits is we ask for a disruption analysis. And so what we do is we look to see, will there be individuals who have a particular practice or care pattern with a set of providers, and will those providers be offered as part of the next solution? We've done that in the past when we've done benefits offerings and RFP processes, and we would absolutely do that here. Can we guarantee that there will be 100% coverage? No. And so what you typically do as an employer is you work with the incoming vendor, if it's different from your current, and you ask them to help you deal with those particular instances of disruption. Again, do you typically have the ability to deal with every one of them? Not possible, typically. But what you do is you try to mitigate and reduce the amount of disruption. One of the things that we've been successful with the task force is the task force has said, we as a group of employees recognize that it's an unrealistic expectation that there's only going to be 100% winners when we make a change. But what we do want to know is that you've made a commitment to the employees to mitigate as much of that disruption as possible and give us solutions so that there is continuity. There is a safety net. There is a process for us to continue. And so we've done that in the past, and we would do that as part of this procurement.
Can you give me an example of someone that might not, it's not even benefit. So can you give me an example of where you had someone who was, I guess, fully insured before, and now all their stuff isn't being covered? I mean, what would be an example of what you just said? I don't know how to phrase it exactly. I mean, you said you've done the analysis before in other areas, so there have been people who haven't, you've had to mitigate the issue. How was it mitigated? And obviously, without invading anybody's privacy, what was the issue and why did it have to be mitigated? Why didn't it fit into that?
So, Chairman Gates, Councilman, a hypothetical example so that we don't deal with any
Exactly.
PHI would be an individual who has a particular specialist that they need. You will have in Arizona a lot of individuals who have very severe allergies. And so if they have a immunologist or a particular specialist that they want to go to, that may or may not be in the new network, new high-performing network. If that is a significant enough impact on our network, meaning the loss of that particular provider, we would go to the vendor and we would say, and we've done this in the past with our carriers, as part of your network, we need you to expand to include this particular practice or provider, because that's a significant issue for us in our health benefits. That would be an example of how you try to ameliorate
So in
the
that
disruption.
case, the problem would really be solved, right? They'd be covered like they were before.
In that
Or
case,
potentially, in that particular case it was.
exactly. Now, as I was saying earlier, the caveat is you cannot always guarantee that you're going to be able to do that. So an alternative would be to say okay, we are unable to provide that particular provider. However, we have worked with the carrier to identify the
Other
following
people who do the same thing.
5 other choices who are open and accepting.
Okay, because at that point, I understand we all like our family physician or whatever, but if an alternative is being provided, at some point it gets to be a little stubborn if you're not willing to try something else with the savings that are involved. And what we're talking about, continuing increases that eventually we're not going to be able to afford, and then we're going to have to scale back healthcare, and nobody wants to do that. So.
Well, and Chairman Gates, Councilman, one of the other things that is a potential benefit of the choice associated with private marketplaces is by having multiple products, you actually have the ability to, for instance, for retirees, split the household.
Right.
So if you have an individual that has particular needs related to cardiac versus oncology for the spouse, you can choose different networks.
And I thought that was a big advantage when we discussed this, Ed. I thought that was that's a
It's a
good
phenomenal
thing.
benefit.
Yeah, I think that's a big benefit. So.
And Councilman Waring, you could have that same situation today with the 2 carriers that we have, because really if you think about networks, either with Cigna or Blue Cross, United, Aetna, any one of them, those are a process that's always evolving. So you have new physicians coming on, physicians going off, facilities coming on, going off. So you could have that today in the current structure that we have.
Right, somebody could not have the specific doctor
Correct.
that they're looking for.
Correct. Yeah.
I'm sorry to interrupt, but we've got we got a hard stop in 30 minutes.
I did not
and-
know about the hard stop. I
Yeah,
apologize.
no problem. No, my apologies. So we had.
I thought these were important issues that he and I had covered,
Yeah.
but hadn't come up here. I
Yeah,
apologize.
no, these are all great questions. I wish we could go on for hours, but let's switch to the retirees. We also have some cards as well. So
All right, so for retirees, just some quick background on retirees. Back in 2007, we unblended our actives and our retirees as part of our GASB 45 solution. So retirees now stand on their own, and retirees pay the full cost of their health insurance. They do get some allowances through MERP and PEP, and those would continue in this process that we're talking about.
So let's translate a little bit.
Okay.
So in 2007, we were all together, retirees and employees, and that basically employees were subsidizing retiree costs. So we separated them. So retirees are on their own and employees are on their own, and it separated or unblended them because of government accounting standards. We had to do that. It's GASB. Now MERP and PEP are very complicated, but it's basically a payment that gets made in retirement to offset healthcare costs. Depending on when you are eligible to retire, you might be in MERP, which is you get a fixed dollar amount a month for life as a retiree. After a certain point in time, we switched it over to where you got a certain amount put into an account for you.
That can be used when you're
That's like a healthcare
post-employment.
savings account, basically.
Correct. That is correct.
Right.
Yep. Okay.
So complicated.
All right. So Medicare plans available in the individual market include Medigap, Medicare Advantage plans, Medicare Part D, and then there are also standalone dental and vision plans that are out there for retirees to select from. So now let's talk about a little bit about the pre-65 group. So in the pre-65 group, retirees would have basically employer-endorsed access. So again, that same marketplace that they could select from a variety of options that meet their individual needs. But the retirees are a little bit different than the active population, and they get really more of what would be a concierge type service in selecting their health insurance. So typically they engage with a licensed benefit advisor who spends time with them on the phone. They're answering those kinds of questions telephonically rather than so much of a web presence. And then, again, marketplace options for them that come up include state and federal marketplaces and then some off-marketplace plans. So lots of different options available for that pre-65 group with that coordinated effort to help them select plans that best meet their
So
needs.
this is what we're going to put into place, or this is what's available, or what?
This is what the Healthcare Task Force has agreed to for the plan year that begins January of 2016, that we would take our pre-Medicare and our Medicare eligible retirees out to the exchange.
Okay. And just a question on that. Why is our healthcare year not aligned with our fiscal year as a city?
Well, we used to have kind of a funky plan year that was an August 1st plan year, but it really makes better sense for us to have our plan years based on a calendar year because of deductibles. So that really makes better sense for us. And as we look at things on the exchanges, it's probably a better option for us to just stay aligned in that calendar year period. We're missing a slide in here. Alrighty. So again, as we talked about the issue, the increased cost of what we're spending for healthcare, not only for our actives, but also for our retirees, that top 10 ongoing expense for the city, the looming excise tax pending out there for us, thinking about what our strategy is with regard to how we provide health care, and looking that really the marketplace is a viable option for both actives and retirees. And when we think about these changes, one of the big positives here is that it puts money in the retirees and in the actives' pockets. It provides saving to the city while still providing quality health care both to our actives and to our employees in kind of that protected environment where we're helping them make that selection of choices.
And I feel like maybe we haven't, you said it puts money in the pockets of the employees. I don't think maybe we fully explained, because based upon what I've heard, it's like, well, if I'm an employee, I'm gonna, I don't really care whether I'm putting money in a high dollar or can you explain really what the financial incentive is that's really kind of, I think, underlying all this?
Right. So that reduced premium cost, so employees aren't paying what they're paying today in premiums through their paycheck every pay cycle. That's one way. But when you're also incentivizing, if you had deductibles in your plan and maybe you're putting money into a health savings account, that money can be rolled over from year to year to help pay for health care. It could be used at the time of retirement as well. So it really allows them to have kind of that health savings account, that safety net to pay for future costs.
Because I think that's been an issue we've been discussing at the council and in the subcommittee, is that concerns that people can't roll over, in a flex spending account, whatever they don't use,
Right.
is just, let's use it or lose it. Under this system, a big piece would be that they could keep that over time and really start building up a nest egg to address healthcare costs.
Right, and typically in a health savings account, you have an employer contribution into that, and then employees can make their own election to put money into that as well. So if you think about over time, they could grow a substantial amount of money in there to help them pay for out-of-pocket costs as an active, or to help them when they're a retiree as well. So just to kind of summarize, exchanges are really just one part of a broader strategic concept. It allows us to look at different channels for delivering health benefits to various work groups, actives, retirees, looking at the overall organizational health strategy and desired employee value proposition. We know that there's substantial savings not only for our actives but also for our retirees. I think one of the things that we've shared in some preliminary analysis is there's substantial savings in the active model, anywhere from $15 to $20 million in year one, and then it grows substantially as we continue on. For our retirees, again, substantial savings for them as well, where they're paying those healthcare costs out of pocket. This has the potential to save our retirees hundreds of dollars a month, if not thousands of dollars a month. The looming excise tax, obviously, we're concerned about that. Access to service and offerings from the exchange provider. All of this just kind of makes it part of a strategic broad policy. So our next steps for retirees is that the retirees will move to the exchanges beginning with the 2016 plan year for both the pre and the post Medicare. We'll issue an RFP here shortly to look for a marketplace provider for us. And then that marketplace will offer increased choices to reduce premium costs for most employees. Our initial analysis shows that the majority of our retirees will come out winners with regard to savings and what they're paying on a monthly basis, and that the city's cost for retiree health insurance will also be reduced.
And to that point, Councilman Waring mentioned $5 million for retirees. Is that an accurate number of what you're anticipating?
Yes, yeah, and I think that's fairly conservative.
That would be in calendar year 2016.
Correct. And we'll continue with our MERP and our PEP programs to make those available for our retirees.
Councilman Waring.
The 5 million is a city savings, but do we have any projection of how much the employees, I guess it depends on what plans they pick.
It does. So
But they should, I mean, maybe not 100% of the employees, but most employees should see a cost savings. Do you have a percentage of, retirees, excuse me.
You want to talk to that?
Yeah, the preliminary modeling, Chairman Gates, Councilman, the preliminary modeling shows that greater than 95% of the retirees will save. And depending upon the plan that we're moving them from and to, it could be average savings of about $350 to $400 a month. So you convert that to an annual figure and you're talking $3,000 to $4,000. It's significant savings.
I think, I'm not sure that got mentioned before, isn't a family of two, is that 1,800 roughly?
Oh, it's more than that. It's about $2,100.
We subsidize
We do.
retirees.
Correct. So you get a MERP payment, or you may have PEP that you can use to reduce or
Right.
offset
Depends on
those
how long
costs
you've
for you.
worked, but
Correct.
okay, so it could be 2,000, that's definitely an appreciable savings for sure.
Yes.
Okay, thank you.
And then for our active population, obviously, the Healthcare Task Force continues to work on our active strategy. But one of the things that we have talked about is going out to rebid our pharmacy contract for the plan year that would begin in January of 2016. So since we went out to market in 2011, there are some savings to be seen through the pharmacy contracting.
Okay. All right. Excellent presentation. What I'd like to do is go to the cards, and then I know my colleagues have additional questions, but I want to make sure that we get to the folks who've been patiently waiting. First, Kim Shepard, and this is to speak comment card. So we're going to do 2 minutes here.
Thank you, Chairman and committee members. We absolutely, truly applaud the work that's been done by the task force, because we understand what the budgetary pressures that are on not only you guys, but also our private employers as well. And as many of you probably know, Cigna has been a partner of the City of Phoenix for nearly 40 years, since 1976. So when City Manager Zerker references the paint on the window panes, we've seen quite a bit of that. So we absolutely applaud the taking the brave step of a fresh look and what do we need to do going forward. And we certainly agree that the only way to actually improve this is actually to improve the health of your employees and actually to engage them in wanting to get their healthcare expenditures down. So we want to just say in this few minutes that we absolutely want to partner with you and support you in all of these efforts you have going forward. We hope to be part of the solution in the future. We are members of many of the exchanges that were referenced. So our goal is to help you vet all of the ideas that are out there, figure out which ones are right for the city of Phoenix. Unfortunately, as you guys, as the task force probably figured out as they were looking at it, there's probably no single silver bullet out there to fix this problem. And it's going to be a combination of a number of things. And as a current partner of yours, we absolutely want to just be here to reinforce our support for you in figuring out what is the best thing for the city of Phoenix and being there with you every step of the way. So thank you for your time today.
Thank you, Ms. Shepard. Appreciate your time. Next is Greta Rogers.
Thank you, Chairman Gates and members of the subcommittee. For those in attendance who don't know me, which is to their advantage, I'm a citizen and I'm not employed. As you can probably tell, I've been retired for a long, long time. At any rate, since we live in a country that has the most expensive healthcare system in the world, and also the top healthcare system in the world, it's been a continuous fight since health insurance was first introduced and employers started covering employees, which was back in the early part of the 1900s. We've come a long way. But one of the things, and I hope the city is doing this with the employees, is to encourage those employees who are not practicing the best conditions of self-maintenance to do that, because that seriously cuts your need for health care and in turn, your costs. It seems to me shopping for these new plans, exchanges, whatever, is kind of like shopping for tires. You're damned if you do and you're damned if you don't. What the source of the excise tax, is this something that Congress passed within the last 2 years in their consummate lack of wisdom? Thank you. In what way, if any, is the health insurance industry affected by this tax? I think that's a question that should be answered. And also, the ultimate purpose by the government in passing this tax was what? Cost saving for the government or screwing the public again? Thank you.
Thank you very much. Okay, good questions. Let's take the first. I mean, I think there was, you kind of nodded your head. So yes, this was imposed by Congress, the tax, which was part of the ACA, right? This is part of that whole structure. And then what impact does that tax, if any, have on the health insurers?
So, Chairman Gates, it will have a dramatic impact on the healthcare marketplace in general. Very specifically to insurers, they will need to work with their clients to help find strategies to lower their costs below the excise tax threshold levels, if at all possible, and to have them maintained below. So it's going to be a significant effort.
And then I'm assuming the intent of Congress by imposing this tax was to force people to lower their health care costs.
So, Councilman Gates, part of what the intent of that excise tax is to help fund for folks that don't have money for insurance and those kinds of things. So really, if you think about all the components of the Affordable Care Act, the reinsurance fee, the PCORI fees, all of that goes to help fund for people that maybe couldn't afford or didn't have health insurance in the past, clinical research, a whole gamut of things that were included in that healthcare reform.
All right, and then we have one card here not to speak, and it's Sean Shepard. Do you care?
No, just making myself available.
Okay, thank you so much for coming down. We appreciate it. All right, with that, other questions from my colleagues? Councilman Waring.
I guess I'll take my second question first. So how easy would this be to undo if we did it and it went wrong? Or is it impossible to undo, or what?
It would not be impossible to undo. It would take work for us to be able to do that, but chances are we would continue with our self-funded plan. So we still have our healthcare trust that's paying our claims and being funded for adverse deviation in future years.
So there wouldn't be a day without coverage for employees or anything like
No.
that? I just want to make sure.
No. What it would take for us, we'd have to go back out to rebid. We'd have to come up with what our plan design was and go back out to rebid to find carriers, just like what we would do today.
How quickly can you turn the ship around if we had to? Because a rebid, all that stuff you're talking about, it does take some time.
6 months, 8 months would be my guess. I mean, those are big, complex procurement processes. I mean, I have done
Right.
lots and lots of procurements in my 9 years in this role. Medical, dental, and pharmacy are probably the top 3 most complex ones that I've done.
And really, the reason why we want to take so much care is because you could, I guess physically, Mary might not be able to withstand it, but you could do that every year. But the disruption on the individuals, and think about it, it's all city employees and their families. We're talking, what, 35? How many thousand people
Close to
have
40,000
coverage
people.
through city health insurance? So you're changing 40,000 people every year. That's just an enormous
The
lift.
disruption, if we tried to go back, be greater or the same than the normal changes we make every few years?
It'd be the
Right.
same.
Be the
Don't
same.
you think
If
it'd be
you went
greater to
back-
switch plans? No?
I
Okay.
mean, we've done that before. We've changed plan design. So I don't necessarily think it's any more work than going forward to go backwards.
I think that's an important point about why maybe this is something we try, given that it sounds like it's not too terrible to undo it if it doesn't work, given the potential benefits. At least to my mind as a policy.
My caution is just, you don't want to do something every year. You don't want to have,
No,
you want
right,
to change
right.
and unchange. But yet, to your point,
If we do
it's doable.
nothing, it's 3 to 7% increases every year as far as the eye can see, right? And that's better than it was, but that's not saying a whole lot. I mean, if Notre Dame's football team goes and beats a high school team, they might celebrate a little bit, but why? So, we're doing a little better than we were
Sorry, I'm
before.
lost.
We were doing a little
You
bit better
lost
than we
me
were
there.
before, which was terrible, and now we're doing better, but we're still losing money every year. So it's bad.
Okay.
So you see, I mean, beating an easy opponent is not. I'm sorry, Bill. You're usually so in tune with me too. This is so
I know, I
distressing.
usually am, yeah.
I don't want to chew up our valuable race to chew. I did have another
One
question.
more comment,
Oh,
though.
sorry.
Yeah.
The only other thing I'd want to tell you is that really when you think about any change that you make, think about when we moved our PPO to have a deductible and co-insurance and we added the high deductible health plan. I mean, we do a comprehensive communication campaign around any changes that we do. I have honestly the most incredible team that works for me in benefits, and we spend hours and hours and hours out in the field. We go to street maintenance, water, parks at 5 o'clock in the morning, 4 o'clock in the morning. I mean, we're up late at night, we're at the airport. So, I mean, that's something that this group is committed to, and they're an incredible team of people that are dedicated to this.
I think you had another question.
I did have another question, and I will say about the last story. A lot of the audience members were laughing, so they got it. Perhaps the fault is yours. I'm sorry.
Yeah, exactly.
So the 5% of retirees who might see cost increases. Now, they were going to see 3 to 7%, and check me if I'm wrong. They should have been building that into their budgets every year. But I mean, they're not getting really hammered, are they? Are they saying increases much greater than the 3 to 7% that they've typically experienced during their years as retirees?
So Chairman Gates, Councilman, the preliminary modeling shows that the average increase would be between $5 and $10 a month
For that 5%.
for that. And actually, the number is actually less than 5. The modeling is showing it to be around 1%.
So we're only going to be doing this next year. It's going to save, I think you said $350 for 95% of the people. And there will be, I mean, I'm not a retiree yet, so I'm not paying them, easy for me to say, but hopefully manageable increases for the other 5%.
Correct.
And the city as a whole will save $5 million. Retirees will save, I guess we'll know next year at this time. Okay, thank you. That's it for me. Thank you. I appreciate it.
Vice Mayor?
I appreciate it. I did Greta leave? Because Greta brought up a really good point.
No,
Yeah.
she said, look at that. She
But
popped.
Greta, she always brings up great points. But the obvious point that we have 14,000 or so city employees, and the Fit for Phoenix program, working along with the Fit Phoenix program. The Fit Phoenix program is this citywide initiative, and with the workplace program, where we're going out into the private sector to encourage people to, live healthier, safer lives, and we should be doing as much as we possibly can internally. And I know that program does do some great things, but I think there needs to be more of a tie-in. Those efforts need to be not only ramped up, and things are happening, and I'm very passionate about the program myself, but I know that we could definitely do more when we have a network of about 60,000 people. When you consider the 14 to 15,000 employees and their families, that's a nice start. Okay, so that's something that we should continue to do. We have, we have partners in the room, and I want to be sure that we include our partners, and they're both here, so it sounds like they are being included into it. Just yesterday, we had another Meet Me Downtown event right downtown, which is sponsored heavily by Blue Cross Blue Shield, for an example. It's important that our partners who've been with us 40 layers of paint ago, to be there with us as we move forward. It's also important, and I'm hoping this is the case, that we have the employee groups here as well, just trying to figure this out. I agree that something has to be done. This is an issue that cannot be ignored. It's kind of like many other major issues that we've been dealing with, where it's, the pension issue, or, whatever other issues that have been coming out in the last couple of years. I think it's just been one major issue after another that has really put a lot of municipalities in a really bad position, because, they took different approaches. We are not shelving things, we're taking it head on, and this conversation is a very important one to have. So I do want to thank you, Ed, and of course you, Councilman Gates, for wanting to have a subcommittee, and with this to be the focus of it. There are pros and cons to everything, and when I see some of the information coming up, when I hear some of the discussion, it sounds like cost shifting. It's like anything else. Okay, we're going to save the money here. It's going to be, lower premiums, but more services. And I'm trying to think, well, how do I know what I need? If I'm picking my insurance package, my homeowner's insurance, I live in Phoenix. Do I need flood insurance? And you're gambling. There are a lot of people who gambled in this last, few months, and we had 200-year storms in the matter of just, it seems like just a few days. What do I need moving forward? I think we definitely should be taking care of our retirees. We have a lot of, and then I think of a program like this, and how well does it work for a family? And certainly now, what do you need? Do you have a family of 4 or 6, or, ranging 4 kids with 12 years apart or whatever? And there's a lot to question about it. I'm okay with, being the pioneer on most things, I think. And this is a tough one, and I'm still, I think we have to be courageous and at least take this on and figure out where this takes us. I'm interested to hear more about the private sector, some that match up with the city of Phoenix, and we've used the private sector to sort of gauge where we are in terms of how what we pay our employees, and there are other things that we do. We are we have 14,000 employees. I know it's very difficult to compare one municipality to another municipality, much less a corporation that's out there. But I'd like to know how big are these corporations that are, that are doing it, and those that are thriving, and do we have an idea? We have to make a calculated decision here, and so there's still a lot of questions for me on this, but I do think that this is definitely a conversation that we have to have. We have to have this conversation. Like Councilman Waring just mentioned, if we do nothing, then what do we? And I think that's what has your focus. I mean, if we do nothing, then what does it mean for all of us? And certainly something has to be done here. I just think we have to tread lightly. The other question is, if we do change, and that part of the discussion. So if we do change, how difficult would it be to change back? Well, I agree. We don't want to be, we don't want to be put in a position to change something. Bless you. Bless you. Annually. Okay. Bless you. Who determines if it works well for the city? I mean, if the city saves $5 million, but our employees are paying, at the end of the day, they're paying far more, well then, does the city win when its employers or employees are not? You know what I mean? So who determines the winner there? And I think by having everyone at the table, it helps us try to figure out, at the end of the day, are we a better city? Are we providing the best possible service? Are we putting our employees in a position to provide the best possible service? Are they healthy? Are they happy? I think that's what we should be going for here, and I think we're headed there. I feel like we're still close. In my opinion, we're closer to the beginning, certainly, and trying to figure a lot of this stuff out.
Thank you, Vice Mayor. Councilman Waring.
So next year, we're doing the retirees, right? This change is being made. It's going to save $5 million in next year.
The retirees have agreed, yes.
And it starts January 1st, so it crosses over budget years. So,
Yeah.
Okay, the current rank and file have not agreed to this, right? To Councilman Valenzuela's point, Vice Mayor Valenzuela's point, you're talking to them, trying to sort of impart that this is a good thing and so forth. I assume they're probably asking questions about the outliers. You're providing the same kind of answer generically that you did to me. Here's what we can do if somehow you get left hanging. And given my sneezing, I'm going to be asking for that allergist you were mentioning after the meeting. But so the timeline on that, when would this decision to implement this in January of 2016, we'd have to move pretty quickly, right? Is that realistic, or?
I think what's raised is really important, that a change like this is one of the most personal things we will do to our employees and their families. So we have to handle it very, very carefully. You all individually have all communicated that. I know you understand that absolutely. Probably if we're going to do this, we got to do it really fast. And I think there's still some unanswered questions that we're trying to resolve in the next 30 days to see if it's even possible to do it that quickly. So I don't have the answer yet to say whether we'll be able and ready to do the actives next year or not. But it is absolutely critical, and it's why the Healthcare Task Force exists, that the employees and the representative employees representing them agree that it is worth the risk, that it is worth the work for the reward that they accept.
And it sounds like you're not there yet.
Not there yet.
But they are being included
Yes.
to his point.
Yes.
Thank you.
As the retiree was included as well.
The retirees decided it was a good deal.
They're in a little different situation
Right.
because they bear 100% of the cost.
Right.
And the intensity of recent years, Mary and I, but more her than me, but more and more retirees are calling and writing saying,
I can't afford this.
I can't even, if I spend my entire pension check, I couldn't buy health insurance with it, particularly our lower paid employees when they retire. So that's really critical that we find something quickly as a solution for our retirees.
So just to let you know, we meet with the Healthcare Task Force on a really regular basis. We typically meet about once a month. Recently, we've been more frequent than that. And we worked with a retiree subcommittee in looking at the exchanges for retirees, and then took that recommendation from that retiree subcommittee back to the full Healthcare Task Force.
And what I would propose is that no later than June, we would come back to this subcommittee with an update as to where we are. Certainly, if we're going to do something really fast, we'll have to be here next month. But at a minimum, we would come back to you in June with a status update.
And I guess a question I would have on that then is what I had asked about earlier, that we have to continue to do our health care on a calendar year. Maybe we're not there now, but could we possibly be there if we went to a fiscal year healthcare system? So in other words, I mean, to me, if we're not focused on, if central to this discussion should absolutely be next fiscal, so 16, 17. That's where we're trying to get. If this is 15 to 20 million, that's half of what we're facing. Would it be worth it to look at possibly moving to a fiscal year two, if we're not there now, but maybe through discussions we could be there in 5 months, is that something we ought to at least be looking at?
Yeah, Chairman Gates, that would be a little bit more difficult, because if you think about folks that are in the high deductible plan or the PPO plan, and they've had a deductible and co-insurance in that plan, and now you're implementing a new plan, and then if you have a current health savings account or you have a flexible spending account, it really becomes complicated to do it in an off calendar year.
Okay, and if that's the case, then I think we just need to have we need to look ourselves in the mirror and say, if we don't do this in the next month, the employee groups need to understand that's 15 or 20 million. I think we know how we've addressed 15 or 20 million in the past. So, I mean, that's just, I know it may be an inconvenience, or people may be concerned about the change, but then, okay, we need to look at that sacrifice word then again. I think this is a time, we may be able to avoid that if people are willing to look at this. That's what I think's on the line. I'm not saying we should recklessly do something, but it sounds like there's a lot of, even worst case scenario situations. There are things that we had to look at. But the other thing too, I think, unfortunately, we didn't have enough of a discussion on, and I apologize for, is what are the other ways to cut healthcare costs, to bring those in line? We've really focused on the exchanges, the private healthcare marketplaces, but what are some of those other things that we could be doing?
So, Chairman Gates, other ways that you can look at cost containment, obviously we talked a little bit about going out to rebid pharmacy. There's money to be saved there, and so we think that that's really important for us to go out and do that.
So is that something that will be proposed and coming back to this subcommittee, or are we doing it?
Our plan is that we're going to do it. We've agreed to that with the Healthcare Task Force, that we would go out to bid on that. I mean, looking at reduced plan designs where maybe you don't have the robust features that we have in our plans today, so you're paring down what's available in your health plans. Cost shifting, we spent some time talking about cost shifting, increasing co-pays, increasing deductibles, increasing co-insurance. I mean, that is probably the primary way to reduce costs in your health plan. Other things are looking at your network structure. Do you go to a more narrow network? Do you go to an accountable care organization? So, I mean, every one of those is a lever that has, pluses and minuses that go along with it. When you look at things like a narrow network, I mean, one of the things that we've talked about at Healthcare Task Force is a pharmacy narrow network. When we look at what we spend for Walgreens and CVS, for example, those are our two biggest expenses for pharmacy. So we look to see what happens if you carve them out and you say you can go to Fry's, Target, Costco, a whole Walmart, a whole plethora of other places to get your pharmacy. What does that do for you? Looking at how you narrow things can reduce costs for you if you're looking at what are your primary cost drivers. I think to kind of talk a little bit to Greta's thing about, are our employees doing self-care? Are they healthy? Are they managing conditions? That's why we do biometric screens and health risk assessments every year, and we've done that year over year for 3 or 4 years. We have 80% participation in that. So engaging your employees in wellness, making sure that they're identifying health conditions before they become catastrophic. So if I have high cholesterol, high blood pressure, and I'm borderline diabetic, getting me in for treatment before I have a cardiac event and I have those other issues that complicate my health. So looking at wellness programs, getting people more active, healthier, eating more fruits and vegetables, looking at kind of that holistic view. There are a whole lot of things that we've done in the last several years. Our pedometer program, for example. You want to add?
Yeah, I think as we've talked about the levers available to us, they get at the point that Vice Mayor Valenzuela made. That's actually just cost shifting to the employee. And so are we truly better off? So we have looked at other options. We've talked about them with the task force. And when weighing the pros and cons, what we've, as a group, decided is there are other levers available to us, but frankly, we don't feel like they're effective, and they result in a painful cost to the employees. And so we need to find more creative approaches that don't just shift the dollars, but really do change the healthcare service delivery system as well as the member accessing it.
Well, thank you to everyone who's participated today. I want to thank our healthcare partners who've joined us and appreciate their perspectives. And I hope that there's a lot of discussion that goes on in the weeks ahead, a very honest discussion at the city about what the pros and cons of these different options. And thank you, Mr. Zerker, for bringing this item forward. And Mary, thanks for your leadership on this issue. It's been a lot of work, but I think it's been a great discussion and the beginning of a further dialogue for the city. And with that, this meeting is adjourned.